Continuing Mobile Education for Emergency Medical Services Providers. This is Geriatrics Psychosocial Issues, Episode 2, Psychology and Aging. By the end of this episode, you should be able to understand some of the psychological changes associated with aging, understand the prevalence of mental illness among older adults, and recognize the importance of screening for depression in older adults.
Part of the answer is that actually our personalities remain very stable as we age. So who we are as people remains pretty much a constant throughout the lifespan. There are some subtle changes that people notice sometimes in the speed at which they can process information mentally, and they may have a little bit more trouble coming up with an occasional name or an occasional specific fact. But most of our intellectual functions remain the same as we age with normal aging. So people who are having significant trouble with their memory or other intellectual functions, that's not normal aging. That's something that's disease of some sort that's worth investigation. In terms of our emotions and our behaviors and our relationships with people, they stay pretty stable. What does change with aging is the circumstances around us. And so we may be facing illnesses or disability in ourselves or in our loved ones. We may find that our roles in life, whether they be with our occupation or with our hobbies or our family relationships, that those might change because of retirement, because of illness, because of changes in the family as the family grows older. And so we have new things to kind of negotiate in our lives as we get older. But we bring the same strengths and sometimes the same limitations that we've had our whole lives to deal with these things as we grow older.
Cognitive abilities, behavior, and personality remain stable as people age. Change in these areas indicate illness and require evaluation. Subtle and occasional decreases in speed at which thoughts are processed are normal.
Older adults suffer from mental illnesses at about the same rate as younger adults. So on average, for older people coming to a primary care doctor, somewhere around 1 in 3 will have some kind of mental illness that's going on. It may be a relatively mild illness, such as mild depression, but whether it be depression or troubles with alcohol or troubles with dementia or memory, adding all those things together, anxiety and other things, it's somewhere around 1 in 3 people. There are additional people who may have had a mental illness of some sort at another point in their life that's now not present, that's now doing better. And those numbers may seem high, but they're actually about what they are for adults of all ages. So actually, older adults experience depression a little bit less often than younger and middle-aged adults, but it's still a pretty common thing. What we call major depression or clinical depression is suffered by about 5%, about 1 in 20 of older adults at any one point in time. So if you take everybody who's coming into a doctor's office, in a primary care office, about 1 in 20 have major depression at that point in time. Another 5 to 10%, so another 1 in 10, will have had depression at some point in the past that's now doing better. And then there are people who suffer from depressive symptoms that are not severe enough to qualify for what we call major depression or clinical depression, but that are still causing them some trouble in their lives, some emotional distress, or maybe affecting their functioning a little bit. And that can be up to 15 or 20% of people can have at least some symptoms of depression without having the full clinical depression.
1 in 3 older adults suffer from some form of mental illness. 1 in 20 suffer from major depression, and many people have depressive symptoms without ever having major depression. Depression is the most common illness seen by EMS, and older adults who commit suicide often see a healthcare provider within weeks of their death.
Well, having seen a number of psychological issues in older adults, I think that we can phrase certain patterns that we see in older adult psychological emergencies or issues. Most commonly, what we'll see is depression, and that's certainly something that is of concern in the elder population, as it is in any age group. But it's different in terms of evaluating it with older adults, because oftentimes it's a later in life loss of interest in what is going on around them, things that have in the past given them happiness, and basically not being able to do what they used to be able to do is often something that drives elder adults or elder folks to depression. In addition to depression, and we'll talk a little bit more about that in a minute, we also see along the same lines suicidal ideations. As they become more depressed, we may see patients that become suicidal. They may also be just ignoring their needs. They may not be eating. They may not be taking their medications appropriately. Those lead down that road of trying to end their own life potentially. They may not seek medical care. So all of those things lead down that kind of psychological depression, suicidal ideation road. So really, in terms of evaluating that depressed adult patient, there's a lot of things that EMS needs to keep in mind. First of all is that empathy is very important in this. So trying to let the patient understand that this is a safe environment for them to talk and to provide information to you and to give you real answers to your questions. It can sometimes be difficult to draw truthful answers out of these elder patients that are depressed and potentially even suicidal or not taking care of themselves. So try and draw them down that road of empathy, respect, trust, to get truthful answers from them in relation to your questions. Asking them about their pill-taking habits, asking them if they've been taking their medications appropriately, asking them specifically when they have last seen their physician or their doctor, and whether or not they are seeking care for conditions that have come up since then. So if things change that they haven't told their provider about, certainly very important. Are they taking care of their meals? There are certainly resources out there if they're unable to cook for themselves. Are they seeking resources to help them deal with, kind of the natural process of aging and a difficulty in taking care of themselves with relation to certain human needs? Certainly, is their hygiene where it should be? Are they just not taking care of themselves? Asking them specifically about what is going on with them that is not having them take care of themselves. Is it because they can't or because they don't have a desire to? Is certainly very important.
Absolutely. Every time an older person has contact with a healthcare provider, it's an opportunity to pick up or to not miss something important going on like depression. Depression affects people's morale, it affects their emotional well-being, it affects their functioning on a day-to-day basis. Depression also puts people at risk for suicide, and we know that most older people who kill themselves suffer from depression, and most of them saw some kind of healthcare professional sometime in the few weeks before they died. So in order to prevent suicide among older people, which is something that we can and need to do better at, we need to have everybody who works with older people be alert for the signs of depression and to ask about it. Absolutely, anybody who's in a healthcare profession can evaluate for depression, and aside from looking and observing the person to see whether they appear sad or emotionally withdrawn or irritable or quick to anger, or whether they talk about not enjoying things the way that they used to, if somebody, a pre-hospital provider, wants to ask about depression, the simple question, have you been feeling depressed or down? Have you lost interest in things? Those couple of questions are really all it takes to open up the doors to talking about maybe other symptoms that the person might be suffering from.
So when we're dealing with patients that, elder patients that may have psychological issues, there are certain things that do change. And I've already spoken about a few of those in terms of our exam of the patient, our interview of the patient changing and trying to build that trust relationship and getting true answers to our questions. It certainly also changes our physical exam of the patient, making sure that there is nothing physically wrong with the patient. Are they malnourished? Doing a good physical exam to determine if their nourishment is where it should be. Are they taking their medications, as I mentioned earlier? Checking that they have a pill-taking strategy, checking their pill bottles to see how many pills should be left in the bottles based on their prescription and when it was filled. Trying to make sure that they are taking them as prescribed. And there's two sides to that. Are they taking too many or are they taking too few? There certainly is opportunity with the number of medications that we see older adults on for them to try to overdose or abuse substances that are prescribed to them for medical conditions. So certainly we need to keep an eye on that. In addition to that, looking at the environment, making sure that there is food in the refrigerator, making sure that there is not dirty, food rotting laying around. Is the environment cluttered? Are there newspapers piled up? Are there animals in the house that aren't being properly taken care of? The old cat environment where nobody's putting out the litter and there's basically cat feces or urine throughout the house. Are they taking care of their own needs? Do they look like they've showered? Do they look like they've cleaned themselves? Is their hair done? Are they dressed appropriately for the weather? All of these things can lead you down the road of potential depression and or suicidal ideation, or just general neglect of themselves, certainly. And all of those things also can be involved in patients that are in caregiver environments. It certainly may not be the caregiver that is abusing the patient. It may be the patient that is being neglectful of themselves. So we have to be careful not to go down that road of abuse, but to objectively report what is found, because it may end up that the caregiver is trying everything in their power to provide what that patient needs, and the patient is simply neglecting themselves because of depression or suicidal ideation.
Anyone can evaluate for depression. Just ask, have you been feeling depressed or down? Or, have you lost interest in things? Use screening keys, empathy and respect, don't assume anything, and get specific answers. After watching this episode, you should understand some of the psychological changes associated with aging, understand the prevalence of mental illness among older adults, and recognize the importance of screening for depression in older adults.